Hi class, so with this lecture we're kind of looking at altered states of consciousness, and we're doing that by looking at how things like drugs and drug substances affect our consciousness. So basically, when it comes to putting things like psychoactive drugs into our system, we know that they cause physical and psychological dependency. So basically, the two, they're different, but they also kind of work together. So with the physical dependency, we're talking about those effects that the drug has on your actual body and kind of your physiology. So once you start taking something like a psychoactive drug and start to become, and you take it consistently to where you feel like you need to take it, which is kind of the psychological part of it, but your body will start to have physical effects of that if you don't take it. So basically we say that, your body will start to crave for that drug. And when you don't get that drug, you go through what we call withdrawal. Maybe you guys have heard it's called DTs. That's something that people who are getting over heroin, they have a really bad physical withdrawal symptoms there. And like I said, we call it the DTs there. And then, even though we have this physical dependency, the more you take any type of a substance that you put into your body, especially when it comes to psychoactive drugs, your body tends to builds up a level of tolerance for that. So what that means is then that your body needs more, it needs a higher dosage of that drug for it to become effective. That's kind of one of the reasons why we see what we call an opioid crisis throughout America, because people are taking these narcotic drugs to help with their pain, and when you're consistently taking a drug like that for a pain mediation, you get to a point to where your body does get used to it, and so therefore they have to start taking more, and it's not like people want to willingly become addicted to their drug, to a drug, but when you're in a lot of pain, that really affects people's motivation and ability to self-efficacy. That just means like how you view your ability to be successful in life, and how you view yourself having a good sense of well-being and reaching optimal happiness in life. And so when you're in a lot of pain physically or mentally, it's hard to do those kind of things. And then, like I said, so then that leads into these problems that we are seeing with drug abuse and even overdoses, drug deaths. All right, so I kind of already mentioned it. So in addition to these physical symptoms that we see, drugs can also cause the psychological dependency. And basically what it is, it just means that you think that without that substance in your life, in your body, you're not going to be able to be successful in life and maintain that sense of well-being and happiness. And any kind of drug that you take has the potential to produce psychological dependency, even physical dependency, and sometimes it's so bad for some people who are so addicted to certain drugs, it's so bad that even if their life is clearly in the tubes and they're at rock bottom, they still feel like they have to have that drug. You hear that a lot with people who do things like heroin, morphine, crack. And then, that adds to one of the reasons, to another point with our opioid crisis that we have too. When it comes to opioids, especially here in Tennessee, in Nashville, they talk about it, that because doctors are limiting those prescriptions, and they're kind of expensive to get, more people are turning to the streets and getting heroin because it's a lot cheaper, and the effects are I would say, they're definitely better than just taking those pills, especially after your body has built up that tolerance for those those opioids and those other opioids. Adding then a different kind of medication, it just kind of cycles back around. You guys know what I mean there? Alright, so why do people get addicted to drugs? Why do we have, substance use disorders? And it goes back to our brains and those neurotransmitters and those hormones that we need to survive. So basically, dopamine is the main chemical in our brains that we need for survival. Dopamine is the neurotransmitter that motivates us. It's our main motivator. It is, so basically, if we were to say we need 3 things in life, we say it's food, water, and dopamine. Dopamine is like our natural feel-good chemical in our bodies, and so that's what we see going on a lot with substance abuse, is that things like for instance methamphetamines, cocaine, crack, they raise those dopamine levels in your body, and of course that can lead to erratic or risky types of behavior. But what it's doing is it's raising those dopamine levels, so it's making us feel good. We feel those high levels of like ecstasy. And so once again, you have to keep taking, people will then keep taking those methamphetamines because they want to get back to that high that we call it there. And just once again, it's just what it is. It's just that dopamine. You're just getting such a rush of dopamine to your brain and in your system, that it gives you those kind of false senses of elevation there. And then what happens, then when you take too much of it, it kind of then, you start to have that adverse effect. You build up that tolerance, and then it makes your dopamine levels go down, and so then you kind of get a little depressed. You don't feel motivated anymore. You don't have those feelings of being high. And so then you have to get more of that dopamine. And then when you couple it in with like those side effects, you say that you have like these drug binges, and then you have I'm forgetting the word now, but you have like the downtime after that. You have that low period, and that's what it is. It's because those dopamine levels have gone down. And so guys, I've got this YouTube video in here. It's actually a lecture this doctor gives to a board of psychologists, and they're just talking about substance use disorders. It is about an hour and a half. But it's really interesting, and I think you guys might enjoy it. I'll make sure to include that when I post this, so you guys can get to it. So drugs raise our dopamine, but they're not, positive and productive ways of doing that. We actually have natural ways that we can raise dopamine in our system, because we are social creatures. Studies seem to show that people who go to therapy, they're really successful when you can have other people there that you can identify with and that you can share with. Best example of that would be AA, Alcoholics Anonymous. One of the reasons that program is so successful and has been so successful for so long, that was started back in the 30s or the 40s, I believe. AA has been around for a long time, and it's because of those kind of because it's faith-based that pulls a lot of people to it. But it's really about that social connecting, having somebody there when especially when you're at a low point, and and you feel like you don't have anybody that you can talk to. So AA kind of use a little psychoanalysis too, because that's kind of a big point of it, is just be able to connect with people, talk, and then listen to what others have to say. And then of course we know things like mindfulness practices, meditative practices, stress relaxation techniques, muscle relaxation techniques, things like yoga, Just all the, we kind of separate those out, but we can lump them all together and call they're all different types of mindfulness practices. And we've seen that definitely helps raise our dopamine levels. And, mindfulness is just about learning to quiet that chattering that goes on in your mind and, really be able to focus on the present. And it not only, and studies have shown that meditation does increase like all the feel-good chemicals that we have in our body, and then it also kind of puts us into those higher states of consciousness, which is rather ironic because some of these psychoactive drugs have the ability to put us in those higher states of consciousness too, and I'll talk about that here in a few minutes. Another way to raise our natural dopamine level is with cognitive behavioral therapy. So we know that behavioral therapy, it's all about observation, right? Remember, guys, the behavioralists, they don't believe in the mind-body connection. They are interested in what makes us tick, be it animal or human, based on what the observer sees and how that test subject is acting, all right? So because they disconnect it from that idea of how our mind and bodies work together, as we have progressed forward in psychology, we have kind of changed that around. We're like, no, you just can't base it on observable behaviors only. We do kind of have to pull in that mental fodder or that mental material that we have going on too. So with cognitive behavioral therapy, it's all that idea: positive thoughts produce positive emotions, behaviors, and interactions with others. Negative thoughts produce negative interactions, behaviors, and engagements with others. So it's all about, it's not about saying, oh, life is all unicorns and rainbows and we all need to run around and be Pollyanna and Susie Sunshine and ignore that there are negative and bad and stressful things in life. It's not about that. It's about more changing of how you engage those stressful, bad, and negative things in life. It is about learning to see those as opportunities for growth, and rather than letting them get you down, when you change the way you look at them, that then change the way, like I said, you react and behave towards those incidents in your life. And so the more you're able to identify the things that stress you out in your life, what we call stressors. When you can identify what they are, you're more aware of them when they come up, and the more you practice to once again, find something positive and productive in that, because when you just stay stuck in that negative energy, you waste your energy, and you waste your ability to move up those levels of self-actualization, that hierarchy of needs that Maslow talks about. So that just goes into our next one there, right? So basically, Maslow's hierarchy of needs. What that is Maslow says that Maslow was a humanist psychologist. He was all about looking into where most of psychology is kind of focused on that abnormal behavior and changing it around. Maslow and the humanists, they're more about looking at positive potential of everybody, right? And so basically Maslow made this little hierarchy of needs. Maybe you guys are familiar with it. You see it's a pyramid that's usually tiered into different levels. That top level, being the little tip of the pyramid there, is self-actualization. That's the highest level of achievement. However, that doesn't mean that we stop learning and growing. Once you reach that level of self-actualization, it's still a process where you have to kind of keep learning and growing so that you don't slide back down those levels. So at the base of the pyramid, the hierarchy of needs there, we have the most basic things that we need to survive. What's that? Food, water, homeostasis. We have to make sure that we have those basic things we need just to make our bodies be able to work. And then next we need security. So we need shelter. So food, water, and shelter. Those are the most basic needs. And then from there we move up to love, belonging, self-esteem, on our way towards self-actualization. society prevents a lot of people from moving up the hierarchy of needs, because those base needs are, in fact, food, water, and shelter. Those needs are not being met for people. And when you're too when you're so focused on thinking about when you're going to get your next meal, where are you going to sleep that night, how do you have time to even think about things like self-actualization? You don't, right? So basically, this natural way to raise dopamine, it's kind of a community type thing, because it's a community and individualistic endeavor. Because, a lot of times people who are addicted to psychoactive drugs, people who have drug dependency disorders, sometimes these people do end up homeless, and that's the biggest thing right there. When you're homeless and you have no, just those basic comforts that we enjoy, it's really hard then to not be in a constant state of depression, and drugs are kind of the only thing that you have to kind of ease your pain there. And so when we can figure out how to help elevate those people and get them the basic needs that they need, and get off those drug dependencies, then that is just going to start getting the chemicals in their bodies and their brains working right. All right, next and last here is physical therapy, and basically what that is exercise. Exercise is good for the body and the mind. It kind of goes along with meditation too. So we see some kind of exercise and mindfulness practices kind of like come together with things like belly dancing, things like yoga, tai chi, martial arts, because those especially with martial arts is not fighting. It's actually it's art. That's why they call it an art. It's an art form of moving your mind and your body together in tangent, so that you're fully, I guess it's so that you're fully utilizing your energy. And the number one rule of martial arts is that it's more about self. It's more about healing and bridging that mind-body gap within yourself, more so than it is for actual attacking somebody. If you know how to do martial arts, you don't attack other people with it. It's the way to protect yourself. So if somebody attacks you, then you're allowed to use those skills, but you never want to do it the other way around. And if you watch the old Bruce Lee movies, you'll see that. That's one thing, that he's never the instigator in any of those fights, even though that's all staged. But that's kind of a key part there to martial arts. So anyway, a little side tangent there. So when it comes to other types of treatment options, we do have abstinence-based programs, and that's just where you have people just go cold turkey. That's a lot of rehab and kind of like drug and alcohol centers. You go into one of those, and usually 30, 60, 90-day program, and if you can get through that program and be clean and sober, then you get to graduate. And a lot of those programs, they teach you how to adjust to going back out into your normal life. And basically with abstinence, that right there, that's the key to abstinence, is that, as you see, you have to have your other areas of life stable. So you have to have those basic needs that Maslow talks about. You can't have somebody who's homeless go into a treatment plan and then just kick them back out on the street at the end and expect them to do better on their own, right? Makes sense, right? So abstinence does work, but it is kind of it's a process, just with any kind of therapy and psychology. There's no such thing as a quick day to the spa is going to cure you. Yes, those things help, but it's all a process, and it's something that you have to stick to and get a routine and keep working on, and keep going back to that therapy and using the resources that those doctors are giving you. So another treatment option is just medication. So that gets, let me go back. That actually, there's some controversy involved in that, because in many ways we're just substituting. So a good one would be methadone. Methadone is a substitution for heroin, and I believe opioids, narcotics in general. And a lot of people then end up getting addicted to the methadone, and methadone can have like adverse side effects on people. Some people do methadone and it causes them to kind of hallucinate. So another example I can think of, a big one too, is just cigarettes and nicotine. A lot of people going through AA or Narcotics Anonymous. That's the other one for if you have a drug dependency, whereas AA is Alcohol Anonymous. But they're really big about, letting people smoke. It's like, it's okay for you to smoke cigarettes, just don't do the other types of drugs. So a lot of controversy there, but then at the same time, there are a lot of drugs that do actually help people wean off. I can't think of a specific name, but fentanyl, I guess. It's the synthetic. No, let me scratch that, guys. I don't want to say anymore because I'm not remembering right now. All right, so just a few statistics here about substance use disorders. We actually used to classify them as abuse and dependency disorders, but now we just say substance use disorders. And this is all according to the DSM-5. Now, the DSM-5 is the Diagnostical and Statistical Manual for Psychological Disorders. And you can think of it as it's like the Bible of psychological disorders. The thing is, like, it's a thick book, and it has I think right now on this 5th edition we have something like 250 disorders that are cited. Europe actually has their own version of the DSM-5, and they actually have a few ones that we haven't included yet. They just came up with online gaming addiction. In Europe, they just classified that as an actual disorder. And then both Europe and with our DSM-5, we're also looking into other things that, because technology, now that we have technology, we're seeing new kinds of disorders coming up. So in addition to internet gaming, things like internet gambling, online gambling is another one we seem to see, even though gambling in general seems to produce a lot of disorders, but now with the ease of technology, we see a rise in that. We see a rise in sexual dysfunction type disorders, or just the one that they're thinking about including when they update the next DSM-5 has to do with just online sex addiction and watching porn, because we found that that does inhibit a lot of people's life there. So just some little interesting things there, and I hope, and sharing that with you guys, you just had a chance there to read what that definition of substance use disorders is. And it's just excessive use of chemicals to the point that it's jeopardizing our physical, social, and job. Just it inhibits our day-to-day life, and because we're taking that, we get tolerance, and then experience withdrawal. We do note that disorders involving drugs and alcohol and nicotine too, we include all of those together. They're most prevalent among adolescents and young adulthood, and we say that when it comes to looking at a lifespan in America of the percentage of people who could develop a substance use disorder, we say it's about 6.2% of the population. And then we note that the drug that people have the greatest potential to use is marijuana, and statistics say something like 33% of Americans have claimed to use marijuana. I would suspect that is a lot higher now with all the medicinal and recreational legalization of that in certain countries. So interesting stuff going on there. And then when we look at the different types of drugs that people are using, we see that it varies with ethnic groups, socioeconomic levels, generations, and even between genders there. All right, and then what we see is that when it comes to things like alcohol use, we say recent studies, so we'll just say in the past 10 years, we don't see an increase and a decrease in that. So it doesn't mean that people are drinking more or less. We're kind of at a stasis with that. Even though it is kind of high, we do note that we do have a high potential of alcoholism in our country. It's very interesting. If you look across the world, Ireland seems to be has a very high rate of alcoholism, and they also have a high rate of Down syndrome. So, you know, if there's some alcohol does, not Down syndrome, I'm sorry, fetal alcohol syndrome. A lot of babies being born with the effects of that. So kind of interesting to note there. And then when it comes to countries that have low levels of fetal alcohol syndrome, we see that mostly in what we consider the developing world. So large parts of the African continent, some parts of South America, but mainly there in the African continent, we see you know, the lowest levels of fetal alcohol syndrome. Pretty interesting stuff there. And then, just like I said, that last one is that it seems like overall maybe about 6% of the population becomes dependent on some kind of drugs. We know that women less likely to take drugs than men. However, it does seem that women maybe prefer popping pills more so than men. We'll get to that in a minute. And this the other statistic is the one that is very interesting, because I would say that the media usually portrays it the opposite. Statistically, white Americans have a higher prevalency rate for having drug problems than Hispanic Americans or African Americans. Now, why that is, you know, that is interesting, because usually if you hear about any type of drug incidents, it seems to involve more minorities. Minorities have been used as scapegoats for certain drug issues in our country too, and so I just find that very interesting, and I probably agree. As far as affluent society, kind of white affluent society go, we see more of those hardcore drugs being utilized. So, all right, let me make this bigger so I can read it. Alrighty, so when it comes, so basically that's just some statistics and a little overview there of what drugs do to us, some of the different things there. And so now what I wanted to do is go through the different groups of drugs we have. So the first group of drugs we have are depressants, or another word we use is sedatives. And alcohol is kind of a strange one. Alcohol and marijuana are both kind of strange, because I've heard, I mean, they can be classified as sedatives, they can be classified as stimulants, and then, you know, for the purpose of the DSM-5, marijuana is classified as an hallucinogenic. So interesting how some of these drugs try to kind of transcend these categories, but at the same time, you know, we make these categories based on the amount of similarities that we're seeing when it comes to like side effects, those tolerance and withdrawal symptoms. So that's how they kind of get grouped together there. Alright, so what we're seeing with this, with the sedatives, is we're seeing they depress the central nervous system. So they're slowing everything down. So, you know, the point of sedatives are to help relax us, help to ease our stress. And at the same time, they also lower our inhibition. So, you know, that can lead to some risky and, you know, delinquent type behaviors there. So our first depressant, and like I said, for the purpose of this class, we're going to say alcohol is a depressant. And so with alcohol use disorder, the main signs of that are that, you know, people need it to function daily. So people will drink alcohol daily, but people can abstain, you know. So that's why alcoholism is such a weird type of disorder, is because it varies with the way people, you know, go about utilizing it. And it comes back to just kind of like what Freud would say, that root, you know, the we call it the etiology. You know, what is that root cause that you feel like you need to have this every day in your life? And so we say that in alcohol, about 11% of adults at least have 1 ounce or have at least a drink per day. We say that maybe 35% can abstain from drinking daily. We say that 50% of alcohol consumed in the United States is by 10% of drinkers, and males drink 2 to 5 times more than females. And then when it comes to cultures, we see that alcohol consumption will vary. In some cultures, it's acceptable that everybody have a glass of wine or have some kind of malt beverage with a meal. It's not like they drink with every meal, but usually like maybe lunch or dinner, whatever their prominent meal for the day is they will enjoy a libation with it. Sometimes, you know, children are even allowed to engage in having drinks too. And it's not like, you know, little 5-year-olds are getting drunk or anything, but it's just kind of, you know, a little sip or something like that, I guess. And then, once again, we see that in most cultures. We see that males maybe tend to consume alcohol more than females. And even though we say that, you know, white people have a more propensity to have higher dependency or you know, higher prevalency rates of engaging in some type of substance abuse. We then note, though, that as far as ethnic differences goes, it seems to be that African Americans and Hispanic Americans, they seem to have a higher rate of dependency. So maybe it's just that, you know, white people try more things, but they don't get as hooked on it, and it goes back to Maslow's hierarchy of needs and kind of socioeconomic positions and social mobility there. That might be why we see some of those dependency rates. All right, and so we probably are all familiar with some of these effects of alcohol. A lot of these drugs have short-term effects and long-term effect. I'm sure we've all seen someone drunk before, if not in person, on the television. So we know that it's kind of easy to know when somebody is drunk, right? And basically, in order to get the effects of alcohol, it really does relate to your dosage, your time, and your weight. So that might be why we say that men drink more than women, because a lot of men are kind of heavier, you know, have a heavier body frame than women. And so in order for that alcohol to process so they get those feel-good effects, they do have to consume more of it. And so it does relate. And really, the rule of thumb is that if you drink 1 drink an hour, so if you just sip on a drink, you don't get as drunk as quickly as if you're just like pounding back drinks. But then once again, like I said, it's just going to change depending on really what size you are, because it all goes back to those inner workings and how your body is processing that alcohol there. All right, and I think it's saying all of that. You guys have had time to read over these short-term effects and long-term effects there. Can't get my slide change. Hang on. There we go. All right, so then our next depressants are our narcotics, which are our opiates. So basically, narcotics, opiates, they stem from opium. Opium natural exists in poppy plants, and so that's where they get it from. And then, of course, knowing that, a lot of these drugs came about by being able to chemically synthesize them in a laboratory, so that's why we kind of say derivatives of that too. Because and at the same time, there are other derivatives that exist in kind of other natural plants. So some of the narcotics: morphine, heroin, codeine. Those should all sound familiar to you. Oxycodones. I couldn't think of the name of them there for a minute. Oxycodones would be another one. And like we said, depressant, they are the ones that they help us with pain, anxiety, tension. They are really addictive because, like I said, tolerance can build up really quickly for them. And then those withdrawal symptoms, those DTs, are pretty bad too. And with a lot of narcotics, we see them administered intravenously, so things morphine, heroin, oxycontin. There was a big, back in when I was in my 20s living in Alabama, there was a big outbreak of people overdosing on oxycodone because they were melting it down and injecting it. And I think mixing it with cocaine too. It's like called a speedball or something, and that causes people to die. That's what killed Chris Farley, the comedian. You guys know him. But so what we see then is with that intravenous administration, that really can cause things like HIV, AIDS, and hepatitis, because people are sharing those needles. And opiates, we know they come in pill form. They can also be oral. And that is oral. I meant that they can also be liquids that you take, and patches. I don't know if any of you guys have ever had like a morphine patch, but those do exist too. And we say that in looking at the whole population, about 7% are likely to become addicted to the opioids. And we see that these statistics are a little outdated. These statistics are from 2013 or 2014, so right at the beginning of when I'd say the opioid crisis started becoming big, because we know that those levels have just skyrocketed in the past just 5 years, maybe 5 years. I'd say I've been in Tennessee about 6 now, and definitely in the past 5 years I've heard way more about it than ever. And we say that men are 4 times more likely to be addicted than women. Next, we have barbiturates, and barbiturates are what we typically call downers. They induce sleep and relaxation. So these are very common, and these are very common in middle-aged people, older people. It's very easy to accidentally overdose on them, and they are lethal when you drink with barbiturates. So a good example of barbiturates would be Quaaludes, and it's kind of funny. Here's a little side, kind of forensics fact. So a lot of affluent white women choose a suicide by overdosing on medication, and barbiturates are their drug of choice. Wait, let me make sure I didn't get this wrong. Yeah, barbiturates are their drug of choice, and it's kind of funny because what they will do is a lot of the times they put on their sexiest little negligee, whatever that they own. They get their hair, makeup, nails done to where they think they're going to just take these pills, drink a bunch of alcohol, lay on their bed, and die, and they're going to be found looking like Sleeping Beauty. But that's not what happens, guys. When you take pills, it's not that medication that kills you. You overdose on pills because when you take too much of them, what do? They make you vomit. And when you're in a state of, you're so relaxed and you're drunk and you don't really realize what's going on, you start to vomit. And so the majority of these women end up being found with their head in the toilet from where they were vomiting, and they choked on their own vomit, or they passed out and drowned in the toilet bowl water there. So my forensics teacher always got a kick out of sharing those types of stories with us, and it is kind of interesting to think about. When it comes to depressants too, and things like barbiturates, because we often combine them with other substances or things like alcohol, we call them a polysubstance dependency. And it's pretty interesting because we don't include nicotine and caffeine in that. But we do consider nicotine and caffeine drugs. Alright, next we have benzodiazepines, and so these are used to reduce tension, anxiety, and once again though, you develop tolerance quickly and you become dependent very quickly. So Valium would be a good example of a benzodiazepine. Alright, so that leads us to our stimulants next. And so depressants depress the central nervous system to induce, euphoria, relaxation, whereas stimulants do the opposite. They speed everything up. So what does that mean, right? They're raising those dopamine levels up, right? So we're getting to feel, really, really, really good when you do stimulants. And we have a few different types of stimulants here. And amphetamines. Those are what we just say, they speed up the central nervous system. They usually suppress your appetite. You kind of become a little insomniatic because your brain's so active and that dopamine's firing so much you don't really need to sleep. So that then kind of boosts your confidence, boosts your ego there. They can be taken orally, intravenously, snorted, and they can also be smoked. So we do see things like ice, things like you think I remember what it's called, the big one that everybody seems to methyl, I can't think of it. You guys know what I'm talking about. Give me a minute and it'll come to me. Let me keep talking here. So methamphetamine, that's the one I'm trying to think of. That's crap, guys, I can't think of it. I'm so sorry. And the thing with amphetamines too is that people can, it really changes people's personality. So people become not suicidal, they can be homicidal, they can be very violent on these types of stimulants. And we do see that once again it's more common with men and among poor people, and it's because a lot of times people just make stuff under their sink, which is what I'm failing to recall the name of what that drug is. People will, it's like you take Sudafed and like battery acid and Comet, and it's like a chemical concoction that people make and then you smoke it. I swear it's methamphetamines, or I'm not saying it right, something like that though. Alright, so it's interesting that we also classify caffeine as a stimulant, yet we don't say that caffeine is an actual disorder, even though a lot of people are, I would say it's probably one of the most common drugs besides sugar that we all need in our life. If you're a big coffee drinker, and there's countless ads, t-shirts, mugs, don't talk to me till I've had my first cup of coffee, but somehow that addiction is okay in society. Our addiction we have to sugar's in everything that we eat, and it's more processed sugar. Our bodies do naturally need some sugar. Our what are they? Our amino acids, our proteins. We need some sugar, but a lot of products that we buy in the grocery stores, they're really inundated with lots of bad sugar. But anyway, so interesting there. So then next, of course, we have nicotine. That is also a stimulant, and like I said, it's we classify it as a stimulant, but at the same time, nicotine can also be a depressant for some people, and we know that it's probably the most preventable. There's a high death rate with smoking, and knowing that though, we know that we can prevent it. If you smoke and you stop smoking, your body will naturally rebuild itself. It's just that dependency. It's really hard to stop smoking cigarettes once you start on it. In fact, it's harder to quit smoking cigarettes than it is to stop doing heroin. That says something for how powerful nicotine is. And a lot of it really has to do with it's not really the nicotine per se. It's more kind of those other chemicals that get put into the cigarettes. Alright, and then next we have cocaine and crack. Cocaine and crack are the same drug. They both come from, cocaine is from, it has something to do with sugar cane. There's some kind of a reed that grows naturally down in like South America, and so they first discovered cocaine during colonialism. They noticed that they noticed that because they had to bring in, slaves from Africa, because the indigenous people of South America, they pretty much had all succumbed to disease from the Europeans come over, so they had to import people. And they had noticed, though, that the natives, they would chew on these particular leaves, like I said, this kind of like canish reed type plant. And they would chew on that, and they noticed that it would give them a burst of energy. So they would use the slave labor. They would they would let them chew those leaves to make them more successful in their production of products there. So there's a little fun historical fact. I kind of say that tongue in cheek, but it's a historical fact, interesting to think about. Oh, here's a funny point. You guys will get a kick out of this. So since they know, so in South America, they're using, they noticed that cocaine is increasing the slaves' productivity. They kind of in parts of the African continent, they tried to do that with marijuana, and they started letting the slave laborers smoke marijuana. But what did they find out? It did not make the people more productive in their endeavors. Everybody kind of got a little lazy from it. So, slavery is terrible, but I do kind of find that that's an amusing story, I believe. So, all right. So, like I said, cocaine and crack are the same drug. It's just different forms of that drug. And we usually think as cocaine as the one that is actually the most pure form of it, but it's actually crack. Crack is the one that is the most purified and potent form, and a lot of times when it comes to cocaine, they cut it with things like baby laxatives, vitamin B, I think is a big one they use to cut cocaine with. And since the 80s, we definitely saw a surge of increase among abuse of cocaine and crack. There are actually some interesting historical evidence that points to the government introducing these things in society as another kind of, to certain groups and social economic levels as a way to, prevent social mobility. And like I said, pretty interesting and compelling facts that might sway you to think it's true if you read through some of that information there. And so basically with cocaine, you snort it, and then with crack, you smoke it, and that's what I said, you're supposed to get that effect quicker. But the thing about it is that it goes away as quickly as that high comes on. It goes away, and that's a lot of time why people get addicted, is because they say they're chasing that first high. They say that when you smoke crack, that first time you smoke it is the most pleasure you'll ever get out of it, because you just never can, your brain just never goes back to that. And so that's why you have to just keep doing it and keep doing it and keep doing it, because it's all about getting back to that euphoric state. And it's a concern in society for many reasons. One, even if it is just a conspiracy about the government introducing that to certain groups and social economic levels, it's still regardless of how it got here and why people are addicted to it, it really is a big problem for all of us, because it is one of those kind of like social health issues. All right, and then last we have the hallucinogens, and some of these I think really are the most interesting of drugs because of the fact that we consider them illegal drugs. And then when you look across culturally, you see that a lot of these illegal substances actually have a purpose, or other cultures have found a purpose for them, and people don't get addicted to them like they do in our more developing nations and like in our society too. So alright, so hallucinogens, we say that they're not considered physiologically addictive. So basically what that means is we can't really say they have adverse effects on our bodies. You know, if you do LSD, you do magic mushrooms, and then you stop doing them, you don't go through DT and withdrawals, you don't build up a tolerance for them. However, even though they're not physiologically addictive, they do have the potential to be psychologically addictive. Okay, so that's important to keep in mind with these. And when it comes to the hallucinogens, we have marijuana as the mildest and the most common. And, you know, we do say that maybe some of those effects we see from smoking nicotine do relate to marijuana. We do have evidence that suggests that it does relate to memory problems and kind of brain developmental issues. And that is, you know, that's true for adolescents and young adults. Our brains don't stop fully developing until we're in our early 30s. And so when you're an adolescent, when you're in your 20s and you're putting these substances into your body, you know, you are messing with the formation of your brain there. So, you know, and then of course that then leads to some of those risky and delinquent behaviors that young adulthood and adolescence seem to be a little more prone to than the rest of us. Before I talk about LSD, I want to go over some of these other ones because LSD is just has a very interesting history. Okay, so let me skip ahead here to PCP. That's phencyclidine is how you say that. The common street name for it is angel dust. Maybe you guys have heard that before from movies. But PCP is it's you know, it's very dangerous, even more so than when people are on stimulants. I would say people who are on you know, they go straight to kind of homicidal, violent behavior, and it's because of these delusions and hallucinations that the drug produces. And a lot of times with these hallucinogenics, with some of the, well, let's say, no, yeah, I'll say it. With most of these, you know, it's poison. You know, you hallucinate because it's the effects of your body being poisoned by that substance, which is true for our next group here, magic mushrooms, or I'm trying to think how to say it. Give me just a minute, guys. Psilocybin, yeah, psilocybin mushrooms. That is the active hallucinogenic psychoactive ingredient is a psilocybin. We also call them psychedelic mushrooms, magic mushrooms, shrooms, mush. If you guys know anything about Grateful Dead, maybe bands like Fish, those kind of jam bands, they seem to kind of promote taking a magical mushroom type culture there. And and so a lot of times, you know, we see that euphoria, we see those altered states of consciousness, altered cognitive processes, a lot of you know, visuals, especially visuals, just visual hallucinations. Time can be altered, and people can have spiritual experiences. So this leads us to the cross-cultural look at so-called drug use. So especially when it comes to things like psilocybin, things like peyote and mescaline. It's very common in cultures around the world. You know, they use these substances specifically for spiritual experiences. So they're not like, hey, it's Friday night, we're in college, we're going to get drunk, and hey, let's take some mushrooms and have some, take some magic mushrooms and go trip, man. You know, the other cultures don't look at it like that. It's serious business for them. You know, if you're going to take this substance and you're going to have that mind altering experience and go into these other states of consciousness, you know, it has to be in a controlled environment, because things can go wrong. You know, there is such thing as bad trips. You know, people can go into those deeper parts of their unconscious, into those bad sides, and not come out. And so I'll say this real quickly. So experts do recommend that if you're ever going to do LSD or to do something like magic mushrooms or peyote, that you have a babysitter. You do it with somebody that is sober, so if you do start going into more that shadow side of your psyche, you have somebody who can talk you back out of it. And that's kind of something when LSD was first introduced into psychology as treatment. That was kind of the point, the psychiatrist was there to observe everything and then help bring the patient back there. So just a little side facts there. Now, when it also comes to psychedelic mushrooms, there is one. The most popular version we would know is it's called Garia. I can't ever remember how to say it specifically or spell it specifically, but go back to jam bands. If any of you are familiar with the Grateful Dead, or if you've just seen those t-shirts, those tie-dye t-shirts that people wear with those little like weird looking Care Bear type figures on it, and there's always like mushrooms and clouds, and it's those little bright red mushrooms with those round like white dots on them. That is the mushroom. That is the actual mushroom that exists and does have these psychedelic properties. And ancient Europe, so kind of more kind of Celtic and kind of pre-Christian, but a little bit up into that too, but we'll say more with the Celtic cultures, they believe that fly agara, that was kind of what people would use to have spiritual experiences. And then, when it started becoming a little more Christianized, this is when would kind of start, they started associating it with witches and saying, the witches take that so that they can go cohort with the devil, and that's how they're able to fly. And I've always found that funny, because I'm like, is it the witches taking the mushrooms and making them fly, or is it the person, or did the person take in and observe the witch and think she was flying? Yeah, think about that, right, guys? So that's just a little kind of and then with Celtic culture too, we see a lot of these types of mushrooms are usually associated with things like nature spirits and fairies. So a lot of times, if you eat mushrooms, or you're in, say, like a ring of mushrooms, then watch out, because you're in for a mind-altering experience when it comes to those types of just transpersonal consciousness and experience there, like I talked about in the Exploring Consciousness lecture. So that then let me get through all of this before I get back to LSD. I'll end with that one. So peyote. So peyote is another one that pretty much the same type of effects as with cycloben, except with peyote, mescaline is that natural occurring psychedelic, and peyote is it's cacti. It's a specific type of cactus, but as you can see, it can be found in different types of cactus species. I think it's with the peyote cactus, that's the one that it's just most concentrated in. And we know that a lot of the southwestern Native American groups, and we say natives in northern Mexico, which kind of same area, just kind of different tribes, so like Navajo, Pueblos, Aztecs, who's the group, Mexica, that's what I'm talking about, Chicano, those would be, because you guys got to remember, it wasn't until the Spanish-American War that the land was divided, and this part was Mexico, and this part was South America. Before the Spanish-American War there, in the early 1900s, before World War I, pretty much from the Mississippi River over, that was all not America. We hadn't had those states yet, and so a lot of it was what we would consider Mexicans living there, because that was, a lot of, that's where their ancestral roots were from. So when you go out to the Southwest, you have a lot of Native American groups that have Native American, and then you have a lot that are just indigenous kind of Mexican, that's right, Mexica or Chicano kind of. So just to kind of point that out there. And so we know that a lot of these groups, like I said, you know, peyote is one of the main things that they use for their religious rites. And once again, you know, this isn't you know, a drunk college night of taking drugs and then, you know, sleeping it off on Sunday. This is serious business for these people. They do these, you know, they have these religious rites so that they can connect to those other states of reality, so they can connect to the spirit world, and so that they can connect to each other. It helps them form a greater bond among their community and their group. So even children as young as 2-3 years old will be administered, you know, peyote, and it's all done under the watchful eye of the shaman and his apprentices, who are not, once again, who are babysitting. They're not, you know, taking this too, when, you know, they would have their own special time that the shaman would take it. It would, and I guess for some of them, it's like the shaman, he'll have his own little time that he does it to prepare for helping the group then to go and transition through these experiences. So he does his little ritual, and then he gets everybody else together and kind of walks them through the ritual for them. So interesting stuff there. Let's see. And so that just leads me then. So when it comes to other types of psychedelics here, like with mushrooms and peyote, there's also in South America, there's a big thing called ayahuasca, and it's or a black drink, they call it, actually a more not so much prehistorically, but just like pre-contact and then contact. So when Europe first started coming here to America and encountering these different, you know, what we call Native American and then Southern as in South American type tribes, down, they had this thing that they call the black drink. And it's just a bunch of different types of herbs that are known to have these hallucinogenic and psychedelic prophecies. And once again, you know, taking ayahuasca, it's about this spiritual experience of it. And so a lot of anthropologists have gone down to take it. There's actually it's just been here recently. It seems to be like the big fun thing for celebrities to go down to South America and have this ayahuasca experience. Wade Davis is a cultural anthropologist that I'm pretty sure talks about it. Graham Hancock, I think, is another one who talks a lot about it. And just there's some really cool stuff when it comes to ayahuasca. Typically people always note going and seeing this, it's like this woman, it's like the goddess of the jungle. I can't remember her name specifically, but a lot of people, even in ancient times, prehistoric times, you know, we have evidence of people seeing this same being when they go and experience ayahuasca. And so it just goes back to, you know, what is consciousness and what are these different like experiences of consciousness, these transpersonal experiences, these paranormal experience, these just altered states of reality, you know, what's really going on there. And then to go along with our groups of, before I wrap up with LSD, because it's my most favorite to talk about, and so that didn't sound good, did it, guys? And so I want to wrap up our categories. We do have a fourth category that we consider other substance use disorders. It would be things like steroid use. We was a big one back in like the 90s and the early, when I was like a teenager and kind of more into my early 20s. GHB is some kind of like steroid people were taking. Laughing gas, performance enhancing substances. So those kind of those just, you know, those other types of drugs. So all right, guys, so that leads us to LSD. LSD was invented and about the I think it was about 1934. It was by a scientist named Alfred Kinyard, I think is how you say his name. But anyway, the scientist came up with LSD, and he didn't know what he was making, all right? So LSD is a lysergic acid, dithalamide. It's a little tongue twister there, so that's why we just say LSD for short. So basically, he was in his laboratory working on developing a drug that would help with headaches and unusual vaginal bleeding, okay? So he didn't know that he had created something that was going to create, that have these hallucinogenic effects. And so just by him, playing around with the different chemicals, he notes that, and this is what's funny about it, he notes that it wasn't until he starts going home, he's riding his bike home, because, that was kind of common back in the 30s and 40s and such. And so he's riding his bike home, and he's noting, as he's riding home, he noticed that his sensations start changing. It's like the birds start to sing bright, sound more cheerful and just happier, and the sky and clouds are brighter, and the trees feel brighter, and the roses smell. Basically he was starting to trip and had really no idea what was going on, but it didn't scare him. He loved it. He was like, this is the greatest feeling in the world. And so then, like I said, that's just a little backstory there. But then it says so they figured out that this was a drug that could produce the same effects as when someone was in a psychotic state of mind. So like people with schizophrenia, and people with, just really bad psychosis, they thought that, that this could be a drug that could help with us to figure that out. So the headache and vaginal bleeding thing got tossed out, and once they started once pharmaceutical companies started producing LSD, and they were sending it out to the psychiatrists to use with their patients, they were encouraging the psychiatrists to take it. They say, if you take this drug, it will put you in the same state, at that same psychotic state as your patients, and therefore it'll give you insight into your patient's mind. And so a lot of those doctors then took it, and they were just like, had their mind blown, like, no pun intended, but just it totally changed the way that they view the world, they view consciousness, they view psychology, mental disorders, treatments, you name it. Stanislav Grof, Grof. He is one of my favorite psychologists, and so he has done a lot of work with LSD and with patients with schizophrenia, and with just looking into different states of consciousness. And he has things, holotropic breath work. He's done things like scream therapy, and he has done work with terminally ill patients. There is a particular type of kind of psychedelic hallucinogen or holotropic drug, that's another word we would call it, that is called ketamine. And he found that it has these hallucinogenic properties. So they've worked with terminally ill patients by, they administer the ketamine, and then they kind of take them through those stages of grief and the stages of just death, which, the denial, acceptance, and bargaining, and I can't remember all of them off the top of my head. But so you take the ketamine, so those patients would take the ketamine, and in many ways they would have a trip that they had actually died. It sounds a little distressing and hard, but what it actually does, it helps. Those people are terminally ill. They know that they're going to die, and rather than, worrying about what that's going to be like, by having those experiences, they're able to process all those emotions and those feelings, and then they're able to live out their last days, a lot happier and healthier than they would have without having that type of a meditative experience induced by ketamine. I've always found that to be really interesting. LSD is the only drug that we know of, or at least last time I took a psychopharmacology class, LSD is the only drug that does not cross the placenta barrier, which means that if a woman is pregnant, that those drugs aren't going to go into the baby's system like we see with alcohol and fetal alcohol syndrome, or we see with like a crack and what we call crack babies, to where, you know, those drugs just go straight through your system. And, you know, and a lot of times the baby is getting the most of that substance, you know, and so that's why we see these really harsh side effects when then these infants and with these newborns, and you know, it follows those people throughout life, those children, those infants. You know, fetal alcohol syndrome, crack babies, you can't, like, you know, because development in the womb has been halted, so we don't really have ways of quite figuring that out just yet, I guess is a way to say that. Now, that does not mean that I encourage anybody to try LSD or encourage any pregnant women to try LSD. My theory is that, looking back to what LSD was originally intended for headaches, migraine, and unusual vaginal bleeding, it seems to me like we're talking more about like OBGYN and kind of women's health issues. So I'm sure in the early days there probably were pregnant women that, you know, unbeknownst to the scientific community, that were taking this drug, and that's kind of then how they figured that out. I'm sure they weren't like, let's see what LSD does to babies. And, you know, it's like one of those unintentional kind of side effects, but it's kind of a positive side effect. Kind of weird. Like I said, don't do LSD. Don't do LSD if you're pregnant. Don't do any drugs if you're pregnant. But, yeah, so that's all I have then. I think, oh, no, let me share this with you too. So, all right, so like I said, so they're in about the 50s and the 60s when they were really starting to administer LSD, and pharmaceutical companies were encouraging the psychiatrists and you know, the scientists to take it themselves. It really did create like this change, this kind of revolution in thinking among the psychology community. But even then, just out in mass society, we kind of see this LSD culture form. There was a guy named Timothy Leary. He was really, I mean, he was all about pushing LSD on people. He thought that it was like the revolutionary drug that everybody needed to take, because, you know, it did change our states of consciousness so much that it was going to be the thing that was going to put us all on the next level. It was going to take us all, you know, up that evolutionary level to the higher states of consciousness, and the world was going to be a bright, sunshiny place. In a nutshell there. But Timothy Leary would travel around the country, and there was actually a whole group of them. I can't ever remember the name, but they would go around the country and they would dose people unexpectedly. So kind of, you know, so you'd be at a party, and you know, back in the 60s, there were a lot of kids in college, or just a lot of kids hanging out in different places, and so Haight-Ashbury would be one, I think, right out in New York or somewhere over there on the Pacific coast. And so they would go, and Timothy Leary and his little band of people would go to these different places, and they would talk about the wonders of LSD. Wanted to start kind of like this whole LSD religion, a whole LSD church. And then, like I said, you know, some people got dosed unexpectedly. And it was through those unexpected dosages, that's then really where these bad trips started to come into play. You know, so these kids were getting dosed, didn't realize what was going on, didn't have anybody to guide them, and they're going into these dark places. You know, the LSD is causing them to go into these dark places in their minds. And so there was kind of a rise in just abnormal behavior and kind of criminal behavior there in the 60s and 70s. So it was a big thing of, you know, of trying to get people to not, or trying to get kids to not do drugs and to stay off of drugs. And one of the biggest ones, it was the show called, oh gosh, now I can't even see, I'm getting old, guys. I can't even remember any of this stuff anymore. Dragnet. An old show called Dragnet. It was about these two cops, and they were, you know, just the facts, man. That was like a famous saying they would always say on that. But they did a whole big episode on like LSD and just the dangers of not doing it. And then to segue and wrap this discussion up here, that then kind of reminds me of then in the 1980s, the big thing of Nancy Reagan, don't do drugs. That is when we saw that influx of kind of crack being introduced into society. And you know, what do we see then? We see the rise of AIDS, HIV, things like hepatitis. So you know, especially among homosexuals and the LGBTQ community, you know, it was a really they were kind of putting, you know, drug use and AIDS were getting, you know, kind of lumped together there, and you know, it was really serious. It was killing a lot of people, and so they just don't do drugs there. So we see that once again, it's just we see in our society that we have these drugs that don't seem to have any positive or productive benefits, and they really do just, you know, bring people down, destroy their self-efficacy. But then it's really interesting when you see these hallucinogenic drugs and we look at those cross-cultural usages of them, and it just makes me wonder if you know, it's the way our culture deals with these types of things, that maybe if we kind of viewed these types of substances as sacred substances like these other cultures do, that we wouldn't have problems with the abuse and addiction and overdoses that we do in our culture. All right, guys, so we're going to go ahead and just end it there, because we've already, I've realized I repeated myself. So we're going to go ahead and call it quits there, guys. Thanks for watching. I hope you learned a little bit about different drugs and the effects they have on our body and our consciousness. Thanks. Bye.